but no problem. So Felice is a good friend and an expert actually on the topic of today, and he's not actually a member of DCB Academy, but is a well-renowned cardiologist in Italy, and especially an expert on DAPT duration, on any antithrombotic treatment after coronary angioplasty. And so when I asked him to help us in giving this resume, I would say, lesson on DAPT after coronary angioplasty, he was excited to accept, and I'm so happy and excited as well to have him here. So Felice, you are on the podium, so please, I think you can share your screen.
Not yet.
Not yet. Yes, now you can share it. This is the team of physicians, at least part of it, the members and fellows of DCB Academy. We also have an host from New York. We have members from all around the globe. Today we don't have Bharat, who is the most eastern one, but we have other good fellows from Asia that are representing Asia. So we have US, we have Europe, and we have Asia. So Felice, please.
So thank you very much, Bernardo. It's a great pleasure for me to have this lecture on the current data on the correct DAPT duration in patients undergoing coronary stenting. And there is quite a lot of evidence on this topic, which is quite still debated. We know that DAPT is the standard of care in patients undergoing coronary stenting, but we know that this therapy is useful to reduce the risk of ischemic events, but anyhow, we are increasing the risk of bleeding complications in patients receiving this treatment. So it is very important to find the so-called sweet spot of dual antiplatelet therapy. So to find the right combination of antithrombotic agents at the right dose and for the right duration, which is the question of Bernardo, to reduce as much as possible the risk of ischemic events, of coronary events, but also coronary non-stent related coronary events at minimal cost of bleeding, which is quite an issue in contemporary cardiology. And one important concept, I think, is that the risk of thrombotic complication and bleeding complication is time dependent and dynamic over time. So that we have that in the first 30 days after coronary stenting, the benefit of a more intense antithrombotic therapy generally outweighs the risk of increased bleeding. But later in time, so this benefit can dissipate with additional time after PCI, favoring therapeutic approaches which are more balanced to consider both the ischemic and also the bleeding risk, so taking into account both risks. So to address the question by Bernardo on the correct DAPT duration in patients undergoing coronary stenting, I'll try to stratify this question into several different questions. And so the first question, which is a quite easy one, I think, is what is the current standard of care, what the current standard of DAPT duration in patients undergoing PCI, and this is quite established in contemporary guidelines, which recommend a duration of 6 months of DAPT in patients undergoing coronary stenting for stable CAD, so for chronic coronary syndrome. On the other hand, we know that the standard DAPT duration after coronary stenting in patients with acute coronary syndrome is 12 months. But we know that this standard duration of therapy is not really the best strategy for most patients. And so we have several things to take into account. So the first point that I would like to address is the following. So is there any clear benefit, any evidence of benefit to extending the standard duration of 6 months, of 12 months DAPT after coronary stenting? And most of the evidence supporting this prolongation of dual antiplatelet therapy for the reduction in ischemic events comes mainly from trials which were conducted more than a decade ago, I think. So this is, for example, the DAPT study, which is a very important trial published on New England Journal of Medicine, in which patients who received a standard dual antiplatelet therapy duration of 12 months were then randomized to receive a prolonged DAPT up to 30 months after PCI or standard of care in the chronic setting, so aspirin monotherapy. And in this study, DPT prolongation produced a reduction in ischemic events in terms of the two co-primary efficacy endpoints, which were stent thrombosis and MACE endpoint. And although there was this ischemic benefit, there was also a trade-off in terms of an increased risk of bleeding. But anyhow, there was a reduction in terms of ischemic events when it was compared a prolonged DPT with aspirin monotherapy. However, one important thing I think is that this trial was conducted several years ago, and so the authors, and particularly Robert Ye, produced a recent new analysis of the findings to explore the findings of the trial, where they try to assess what is the current treatment effect of the strategy investigated in the DPT study. And so they compared the treatment effect of extended DPT in the DPT study versus the contemporary treatment effect of the same strategy in a real-world population. And these are the main findings. What they found is that with solid line, you have the benefit observed in the original trial. With the dotted line, you have the data from the real-world contemporary population. And as you can see here, there was much more benefit in the original trial of what was estimated in a contemporary population of PCI patients. And this was both for stent thrombosis and for MACE. So there was an evidence of less ischemic benefit as compared with the original DAPT study, which was conducted between 2009 and 2011, as compared with this new reanalysis of the data conducted in patients undergoing stenting between 2016 and 2017. On the other hand, they observed the same increased risk in bleeding in patients, in the contemporary patients, as compared with the original DPT study. So one important thing I think is that when we observe this benefit of extending DPT in studies that were conducted more than 10 years ago, then we have probably reassessed this potential benefit, and maybe there is an attenuation of prolonging DPT for reducing ischemic events in contemporary patient population. Another question I think that is important is that is there any benefit of shortening the duration of dual antiplatelet therapy as compared with the standard DPT of 6 or 12 months? And in this case, I think that we have to take into account how we're going to discontinue DPT. And so if we are trying to continue antiplatelet monotherapy with aspirin, or if we are continuing after DPT discontinuation with a P2Y12 inhibitor. And this is a very important decision because we have several studies that investigated the opportunity to reduce the duration of dual antiplatelet therapy and then continuing with an aspirin monotherapy. And this trial provided some variable evidence, but generally unfavorable results in terms of ischemic protection. This is an example of these trials, the SMART-8 trial of patients undergoing PCI for an acute coronary syndrome, and patients were randomized to a short DPT of 6 months as compared with a standard DPT of 12 months. Although for the primary endpoint of MACE, the short DPT strategy followed by aspirin monotherapy was non-inferior for the MACE endpoint, the primary endpoint. On the right, you can see that with a short DPT followed by aspirin monotherapy as compared to a standard DPT duration of 12 months, there was a significant increase in the risk of myocardial infarction, so coronary ischemic events. And this risk was particularly pronounced if we compare the landmark analysis, which compared the data after 6 months. So at the time when the DPT was discontinued and aspirin monotherapy was started in the experimental strategy. In this case, you can see that the hazard ratio was 5. So 5 times increase in the risk of ischemic events comparing aspirin monotherapy versus dual antiplatelet therapy. And in addition, we know that there are some uncertainties regarding the safety of prolonging of long-term therapy with aspirin in terms of gastrointestinal bleeding and also intracranial hemorrhage. So the other option that today has some evidence supporting this strategy is to continue with a P2Y12 inhibitor monotherapy after dual antiplatelet therapy discontinuation. And several trials have been conducted in this setting, and in this individual patient level meta-analysis. We pulled available data from randomized controlled trials comparing a P2Y12 inhibitor monotherapy after 1 to 3 months of dual antiplatelet therapy versus standard DPT in patients undergoing coronary revascularization. These are the data from the 6 trials, more than 23,000 patients enrolled and stratified in P2Y12 inhibitor monotherapy versus DPT. And here you have the main results of this meta-analysis. As you can see here, a P2Y12 inhibitor monotherapy was as effective as a standard DPT for the prevention of ischemic events, namely death, myocardial infarction, or stroke, with a neutral hazard ratio. On the other hand, P2Y12 inhibitor monotherapy was able to reduce by approximately 50% the risk of major bleeding, so prognostically relevant bleeding, so no trade-off, no risk of increase in ischemic events with P2Y12 inhibitor monotherapy after a short DPT as compared with standard DPT, and a very large bleeding benefit for this monotherapy strategy. And based on this evidence, the recent guidelines from the ESC have incorporated this recommendation, recommending with a class 2A level of evidence A, the opportunity to use a strategy of a short DPT, like 3 months, followed by P2Y12 inhibitor monotherapy in patients with a PCI for ACS. Another important concept that has been recently investigated in trials and also in meta-analysis is whether the type of P2Y12 inhibitor monotherapy can have an impact on the efficacy and safety of this strategy. And most of the evidence have been collected for the clopidogrel monotherapy and for ticagrelor monotherapy versus DPT. And the available trials have been summarized in this recent meta-analysis, which we have recently published in JAMA Cardiology. In this meta-analysis, we pulled data from 6 randomized trials comparing ticagrelor monotherapy or clopidogrel monotherapy versus standard DPT, and we provided a stratified analysis by type of P2Y12 inhibitor. And so in this recent meta-analysis, we found that ticagrelor monotherapy was as effective as dual antiplatelet therapy after PCI for the prevention of ischemic events, death, MI, or stroke, as you can see on the left. And then the ticagrelor monotherapy strategy was also associated with a significant benefit in terms of bleeding reduction, so major bleeding reduction, approximately 50%. On the other hand, clopidogrel monotherapy was less effective than dual antiplatelet therapy in patients undergoing PCI, but was associated with a similar reduction in the risk of bleeding. So in case of ticagrelor, you have that monotherapy is as effective as dual antiplatelet therapy, so you do not need aspirin on top of ticagrelor for cardiovascular protection, and then you can reduce bleeding. In case of clopidogrel, you still need probably aspirin to provide sufficient protection early after PCI and ACS to protect against death, MI, or stroke. And if you discontinue aspirin, in any case, you have some bleeding benefits also in case of clopidogrel. Another important question, I think, is should we consider a different duration of dual antiplatelet therapy in patients with high ischemic risk, which is another very controversial point. And most of the evidence after PCI was mainly condensed in this pooled analysis, which included trials testing standard DPT of 12 months versus a prolonged DPT after complex PCI, which is an important setting and high risk, high ischemic risk setting for patients undergoing PCI. This analysis by Gennaro Giustino and colleagues of several years ago showed that in patients with complex PCI, a prolonged DPT as compared with a standard DPT followed by aspirin monotherapy was associated with a reduction in terms of ischemic events. So prolonged DPT was better for ischemic prevention than aspirin monotherapy actually in the long term, whereas no benefit was observed in patients with non-complex PCI. In any case, there was an increased risk of bleeding in patients with complex PCI, which somehow counterbalanced this ischemic benefit of prolonging DPT as compared to as aspirin monotherapy. We've tried to update this evidence, pulling data from trials which tested and compared P2Y12 inhibitor monotherapy versus standard DPT in patients undergoing complex PCI. And in this case, DPT prolongation as compared with P2Y12 inhibitor monotherapy was not associated with a benefit, with an ischemic benefit in patients with complex PCI or in patients without complex PCI. So P2Y12 inhibitor monotherapy after a short DPT was as effective as a prolonged DPT for ischemic protection and was associated also in this case with a significant reduction in terms of major bleeding. So complex PCI should not guide the decision when we're using P2Y12 inhibitor monotherapy. We can use this strategy safely for ischemic protection and to reduce bleeding in patients with complex PCI and as well as in patients with non-complex PCI. Another important point, I think, is how can we shorten, how far can we shorten DPT in the other important group, which is the patients with high bleeding risk. And in this case, most of the evidence, of the randomized evidence, comes from the maggio DPT trial, which is a very important trial where patients undergoing with HBR, undergoing PCI, at 30 days after coronary stenting with an ultimaster stent, underwent randomization to an abbreviated DPT strategy, which means discontinuing DPT at 30 days follow-up after coronary stenting versus a standard strategy prolonging DPT for at least 3 months after coronary stenting. These are the criteria that were used to select this HBR population in the master DPT, mainly age above 75 years old, but also precise DPT above 25, indication to oral anticoagulation, and so on. And here are the main results of the trial. The abbreviated DPT strategy of only 1 month DPT was associated with, was non-inferior for NACE as compared with the standard DPT in the per protocol population. Similarly, the risk of MACE was similar in the abbreviated DPT strategy versus standard DPT strategy. So abbreviated DPT was non-inferior to the standard DPT in this HBR population. And as you can expect, there was a significant reduction of bleeding events in patients receiving abbreviated DPT of only 1 month as compared with a standard DPT. So I think that in this population of patients with HBR, 1 month of dual antiplatelet therapy is the correct DPT to use to improve outcomes in this specific population. My last comments are regarding the B-risk patients. So patients with both high ischemic risk and also high bleeding risk, which are quite common in clinical practice, and still the treatment of these patients remain controversial in our practice. And one recent study has addressed this specific study population, which is the OPTI-B risk trial. In the OPTI-B risk trial, patients that were considered at high ischemic risk and also high bleeding risk received DPT after coronary stenting for 9 to 12 months, and then patients were randomized to continuing dual antiplatelet therapy with clopidogrel plus aspirin, or to discontinuing aspirin and continuing with clopidogrel monotherapy. So in long term, they tried to assess whether clopidogrel monotherapy was superior or not to clopidogrel plus aspirin, so the standard DPT strategy. These are the criteria for selecting the high bleeding risk patients and the high ischemic risk patients. And I have to say that these are not very standardized criteria, but they are useful to select this population and are quite study-specific criteria. But here are the main results of the trial. In the OPTI-B risk trial, in patients with B risk, so high ischemic risk and high bleeding risk, a clopidogrel monotherapy strategy was associated with a reduction in the risk of the primary endpoint of bleeding, of clinically relevant bleeding, defined as BARC types 2, 3, or 5. So the study found the superiority of clopidogrel monotherapy as compared with the standard DPT strategy in this B-risk population. And there was also the superiority of the clopidogrel monotherapy as compared with DPT in terms of ischemic events. So clopidogrel monotherapy was superior to standard DPT for both bleeding endpoints and the ischemic endpoints. And so here are my conclusions regarding what are the current data regarding the correct DPT duration after coronary stenting. That we know that standard DPT recommended by guidelines is 6-12 months based on the current guidelines. Whether or not there is a benefit to extending DPT, I think that not with when we consider the modern PCI technique and also the current DS stenting, so not in the contemporary practice. Is there a benefit to shortening DPT? Yes, but if we continue with P2Y12 inhibitor monotherapy, which provides same effectiveness as standard DPT and better bleeding outcomes. Should we prolong DPT in patients with high ischemic risk, like complex PCI patients? I would say no. If we continue with a P2Y12 inhibitor monotherapy after DPT discontinuation, how far can we shorten DPT in high bleeding risk patients up to 1 month, according to the evidence from the master DPT trial, and what is the duration for B-risk patients for DPT? I have to say that in this case, the bleeding risk assessment should prevail, and I will go more for a short DPT strategy. And thank you very much.
Thanks a lot, Felice, for this very comprehensive lesson done in a timely manner. I appreciate that you were able to say everything and synthesize everything in less than 20 minutes, probably. And that's the way to go. You know, yes, there are still some doubts about, for example, the B-risk patient, because in that study, patients were randomized only after minimum of 9 months of DAPT, which is something that after coronary stenting in a B-risk patient, I find a little bit debatable. So don't you think that in these patients, probably as you said, duration of DAPT should be shortened, but shortened to less than 9 months? This is a question that I wanted to pose you.
Yes. Thank you for this question, Bernardo, and I agree. I think that we can, the OptiB-Risk trial used this time for enrollment up to 12 months, actually. But there are also data, for example, from the master DPT in HBR patients, also in the complex PCI sub-analysis of the trial, where you can see that short DPT of 1 month is effective and safe in complex PCI patients and non-complex PCI patients. So I think that probably when we have HBR patients, 1 or no more than 3 months dual antiplatelet therapy, I think is enough. Of course, these data apply mainly to patients with successful PCI. When we have complex PCI, but we are using, for example, imaging to improve the stenting, so we are safe on how the procedure was done. And I would say that these data do not entirely apply, for example, in patients where we do not have a successful PCI. So in that case, I would be probably I would pay more attention on when to discontinue DPT. But if we have successful PCI with a contemporary DS, also in complex PCI patients, I would go for 1 or no more than 3 months DPT duration. I agree.
And do you think that there is any room in the high bleeding, but also in this B patient, for a more potent P2Y12 inhibitor instead of clopidogrel after the first short duration of the APT?
Yes, I think that when we discontinue aspirin early, then we are really reducing the risk of bleeding. So particularly in the B-risk setting and in the early phase after PCI, like up to 3 months or 6 months, I will be more confident in using ticagrelor as a monotherapy, and then probably to de-escalate to clopidogrel monotherapy. But in the very first time after PCI, like at 1 month, I think that if we decide to de-escalate to clopidogrel monotherapy, then we have to accept that we are somehow reducing the risk of bleeding, but we have to accept that we are likely to increasing in some patients also the risk of ischemic complication. With ticagrelor, you have a potent inhibition of the P2Y12 receptor. You have a very consistent effect. You have no problem like with the poor responsiveness, which is another matter of high debate. No resistance. So you know that your drug is okay, and so in these patients, I will go for ticagrelor monotherapy.
Very clear. And what about using, de-escalating from 90 to 60 milligrams? Do you think that we should wait for 1 year in these patients or go a little bit earlier also?
I think that this is a very nice question. And current evidence for ticagrelor monotherapy are only based on ticagrelor with 90 milligram. We have to say that in the Pegasus trial, the efficacy of the 90 milligram was almost the same of the 60 milligram. So probably the best dose regimen for ticagrelor is 60 milligram to balance ischemic and bleeding risk. We have no data, so maybe there was probably a problem. Maybe there was an issue in the phase 2 trials when they decided that the best dosing was for 90, but now we have only data. So if there would be a study, it would be really interesting to see if and I think that also 60 milligram is a very effective drug. You have a consistent inhibition of platelets. So that would be a very nice opportunity for patients. But so far, we do not have,
there is no data.
We do not know data, actually.
I have a question. May I ask you?
Please.
Sure, please.
Thank you very much for your presentation. Routinely in the guidelines, it has been mentioned that after in case of acute coronary syndrome, if after the 1 year duration, you are switching to aspirin-only therapy, and aspirin-only therapy will be for the lifelong, it is mentioned. So when we are switching to, when we are stopping the aspirin and we are switching towards ticagrelor, and for 1 year, and it should be continued as a lifelong, as a monotherapy, or it will be having a certain duration, limit of duration, so that will stop at certain duration, or it will be continued like a lifelong therapy?
Thank you very much for your question. I think that most of the evidence of benefit of ticagrelor monotherapy is up to 1 year. So this strategy could be also continued after the first year, but there is not really evidence supporting this strategy. And I think that overall the evidence suggests that while in the early phase after PCI, there is an issue with clopidogrel monotherapy, especially in the ACS patients, in the long term, I think that the two drugs work fine. So I think that there is no really an issue with clopidogrel in the long term. At least this is what the evidence suggests. So in patients after the first year after PCI, I think that we can continue safely with clopidogrel. And I think that this strategy has better data than the aspirin monotherapy. So we made another meta-analysis, the Panther meta-analysis, where we compared P2Y12 inhibitor monotherapy of both clopidogrel or ticagrelor versus aspirin, and P2Y12 inhibitor was better. And this effect was consistent for clopidogrel and for ticagrelor. So for the long term, I do not think that we need, except maybe in patients at very high risk, recurrent ACS, recurrent stent thrombosis, but these are really selected cases. For the majority of patients, I think that clopidogrel monotherapy is a safe strategy for both the efficacy and for both the bleeding benefit.
Thank you.
Great. Other questions? Well, I have another question, actually. So, MasterDAPT used the Terumo stent. In other trials, there was a more liberal usage of drug-eluting stent. So which is your position on do you ever tailor your antiplatelet therapy according to the bleeding, to the thrombotic risk, to the stent used?
My perception is that current generation DS are performing very similarly. I do not think there is a big difference. For massive DPT, they use one stent, but I think that the results would not be different with contemporary DS. And also there was, for example, a sub-analysis of the Twilight trial with the ticagrelor monotherapy after 3 months. They made this analysis by type of stent, and there was no difference across no heterogeneity in the treatment effect. So I think that if we perform successful PCI better, if this is supported with imaging, with OCT, with IVUS, with contemporary DS, then I think that we can safely discontinue aspirin better after 1 or 3 months of dual antiplatelet therapy.
Yeah, I agree with you. Currently available drug-eluting stents share a class effect in terms of thrombotic risk or antithrombotic one. I had a case today that was quite interesting. It was a complex RCA and an LED angioplasty that I did in another center during the proctorship. But in this patient, they implanted a drug-eluting stent in the proximal circ 3 days ago. Okay, then there was a disease just after the stent, so they did thrombus aspiration, predilatation, and TES implantation, a 4-0. There was disease distally, and they implanted another stent in the, I would say, obtuse marginal, in a long obtuse marginal stent. And it was a quite long stent. The second one was a 28 or 32 maybe. So I asked them, since I was proctoring them for complex PCI with DCB, I told them, okay, I can understand you put a first stent, there was still some disease after predilatation, but then why did you put a stent there and not a DCB? And they said, yes, because in the STEMI setting, there was still some disease, and I prefer to put a stent. Okay, it's acceptable. You know, they were not an experienced center on DCB, so this is why I was there today. After that, we did all of the PCIs, we did rota, we did cutting, and a full DCB. And then we took the last shot in an orthogonal view. And in this was a cranial view where we just saw very clearly the circ. And there was a fracture in the second stent placed in the circ, because there was it was placed probably in the same place where the circ is transforming into obtuse marginal. So in that area, the movement of the heart is doing like this. And after 3 days, there was a fracture in a stent just implanted. This, you know, very, very, I'm not telling you the name of the brand, but the very, very thin strut stents. So I think that in the end, after all you have said, I agree with you that the key message is the difference on the fate of the patient is done at the time of PCI. With your thinking, your up-to-date knowledge of the clinical trials and the literature, and with an extensive usage of intravascular imaging, mostly in the complex setting. This is making the difference.
Yes, I entirely agree. We should not create patients who are dependent on the APT. Otherwise, we will never be able to discontinue. We have recurrence of events. So if we optimize the results in the index procedure, then we can safely discontinue the APT and go for the escalation strategy, etc. If we make some errors in the evaluation and need the treatment of the procedure of implanting stent, etc., then really we have issue with patients. We are not able to de-escalate. We have recurrent events, stent thrombosis, etc. So that is really, this is very important message, I think.
Because a stent is like a diamond. A stent is forever.
Forever, yeah.
Yeah. Thanks a lot, Felice. It was amazing. You know, really, we learned a lot. Thanks a lot.
You're really welcome. It was really a pleasure for me.